that happening? Has everyone had a message saying, oh yeah, I'm recording? Good. Great. Lovely. Well, welcome everybody. As I said, it's so nice to see so many people online supporting our early stage career members. The proceedings for the afternoon are going to be, and I need to share my screen now, so please bear with me. This is another. Here we are. So welcome. And the proceedings are going to follow. We're going to do the awarding of the Keith Woods Essay Prizes and certificates. And then we're going to have the posters that have been selected as the top 4 posters for the BASCD Borough Foundation Prize in this order, post number 3, 7, 8 and 10. And then at the end, there will be the awarding of the prizes and some words from Nigel Borrow from the Borrow Foundation, and I will close. So that's the order of the proceedings. So a little bit about who are BASCD, and so the full title is the British Association for the Study of Community Dentistry, and we are the UK's professional association for the science, philosophy and practice of promoting oral health in society. And we believe that, you know, prevention is better than cure, and that's some of the common founding principles that we have in similarity with the Borrow Foundation. And our activities involve epidemiology, research, teaching and training, oral health improvement, the work as well of our consultant body and the specialists, and really BASCD is the membership. I always keep saying, what is BASCD? BASCD is the membership, and the friends of BASCD support BASCD in these principles. So that's who we are. And I'm the current president at the moment until next spring. So I'm just trying to work out why I can't see you all, and there we are. I just need to bring on screen. Don't understand why I can't see you all, but there we are. Right. Anyway, so without further ado, I'm going to introduce the winner and a commendation, someone who's received a commendation for the Keith Woods essay. Now, the Keith Woods essay competition is dedicated to one of our founding members, Keith Woods. He took a special interest in the national surveys of children's and adult dental health, very involved in the epidemiology, and that really was core of my work in Wales while I was a senior lecturer in dental public health. And he participated in a survey of dental health of Northwest prisoners. Seeing the growth and benefits of modern technology helped to develop computer software for the gathering and interpretation of oral health data. And throughout my career, I used to open up a package called Dental Survey Plus, and at the top there were a couple of names. One was Keith Woods and another one John Clewett, who I worked very closely with in Wales. And every time I opened up this package, I was reminded of the fact that Keith was involved in designing this software. And the essay competition is designed to foster the interest of the next generation of dental professionals in public health dentistry. And this competition is open to any undergraduate from dentistry, dental therapy, dental hygiene or dental nursing registered in a dental school in the UK. And for 2021, the title, which I have to say, if you've got the answers, then, you know, we could do with some pointers, ladies who are online who've written the essays, what the oral healthcare workforce should look like in the United Kingdom by the middle of the 21st century. So, and I have got the screen. I don't understand now why I can't have the PowerPoint up. And anyway, so this is a bit frustrating for me now. So if I'd like to introduce you to Alexandra Krajcek. I hope I pronounced your surname correctly, from the University of Liverpool, whose essay was very, very well received by the judges. And we also like to commend Shireen Hussain, who came as a worthy runner-up. And what I'd like to do now, I think, is stop sharing, if I can. Work out how to do this because I can't find the Teams. There we are. I'll stop sharing for a moment so that Alex and Shireen perhaps can have a word. And what impresses us is that you are interested in prevention and promotion, because generally speaking, it takes a little while for that penny to sort of drop or to click with some in the profession. So it's really nice to see that you have engaged with the work of BASCD and our principles. So Alex, would you like to say a few words?
Hi, you guys. So first of all, impressive pronunciation of my surname. I'm really glad you got it nearly spot on.
Oh, good. I'm pleased.
Thank you very much for a very, very warm welcome. And I just wanted to say that I am extremely grateful for having had won the Keith Woods Essay Prize this year. So thank you very much, everybody. And also huge congratulations to Shireen on her essay this year as well. So congrats. Thank you very much.
Thanks, Alex. And Shireen, would you like to say something?
Yeah, hi everyone. I just want to say thank you so much for this opportunity, and I'm really appreciative that I got second place, and well done to Alexandra as well.
It's lovely. Thanks both. And there's an article on, I don't know if you're aware, on the BASCD website about you both winning the prize, and also a little bit about your background and why you're interested in dental public health, and which I think will encourage other earlier stage career folks to come and have a go at writing an essay or presenting a poster at the Borrow Foundation Prize. So thanks ever so much. I will send certificates on to you, and I've got emails lined up for that, and I'll send those later. But thanks for joining us, and you're very welcome to stay to hear the poster presentations, and perhaps that would be the next stage in your career in a couple of years' time, to be able to present a poster at this event, which I would imagine will hopefully be in person as opposed to online. But so thank you, ladies. Thanks very much. Okay, so we are now moving on to the next part of the schedule of the afternoon, and I'm just going to bring up the PowerPoint again. She says, hoping it works. Right, have I shut it down? From current slide. Can everyone see Shireen's smiling face? Yeah, it's great. There we are, in the right place. So we move on now to the BASCD Borrow Foundation Early Career Poster Prize. And the poster award is sponsored by BASCD and the Borrow Foundation, who are actively engaged in promoting oral health and disease prevention. And the title of this year's award is Working Together to Assess the Impact of COVID on Oral Health or Dental Services. Now, I'd just like to say a little bit about the Borrow Foundation and the people who work there. Margaret Woodward, who works on behalf of the Borrow Foundation with Nigel Borrow, is a stalwart member of BASCD and has been a great support to me during my presidency. But I first came across the Borrow Foundation many moons ago, when in their earlier days they were championing milk fluoridation in schools. And as dental public health has progressed, their work has come to sort of a broader church of prevention and promotion, but really focusing around children. And their work really parallels with the work of BASCD, and we're so pleased that they're supporting us with this event today. And thank you to Nigel for coming to give a congratulation, vote of congratulations to the poster participants. So as we move on, we're going to have the poster presentations. And now the first one on the agenda is from, I've got, all right, who have we got first? Is it Myra Hurley?
Yeah, Hurley.
And hi, Myra. So Myra, are you wanting me to present your slides?
Yeah, I have concerns about my Wi-Fi connection, so I think it might be better if you could do that. It'd be great. Thank you.
Definitely will. I'll bring that up now. So what we're going to be focusing in on is Myra's poster, which focuses on assessing the impact of COVID-19 restrictions on access to HSE dental GA for people with disabilities, and I can't spell in. I don't know what I was focusing on there. Do you think it might have been a gin and tonic? 2 regional centres in the Republic of Ireland. So I'm just going to stop presenting that one and then make sure I've got the other one open. I talk a lot to myself. I don't know if that's a good thing or a bad thing, but we'll share another one. And we need... Here we are. I'm hoping this is it from there.
Yep.
Myra, is that what we should
Yep.
be seeing? Yeah,
suspense
great.
was killing there. Thank you. That looks great.
So just give me the nod, Myra, when you need me to move on.
Certainly. Okay, thank you very much. First of all, I want to thank you for selecting my poster, and absolutely thrilled to be able to share this research with you at this platform. So I'll start by giving you a bit of the background to the Irish context for the study. The Dental General Anaesthetic Service in Ireland is publicly funded by the Public Dental Service with the Health Service Executive HSE. So it's very much like the Irish equivalent of your community dental service in the UK. So it provides services to school children in targeted classes and emergency care up to the age of 16 years, and also special care patients. This is informed by the Dental Health Action Plan of 1994. So within the existing structures, we're currently struggling really to meet the needs of these very large population groups, and reform of our public dental system and our public dental service has been addressed in the new National Oral Health Policy, Smile Agus Sláinte, which is published in April 2019. This proposes to redirect our public dental services towards the care of special care patients and vulnerable populations going forward. So in summary, it's a system that's under pressure and reform is planned. So we're coming to then the arrival of COVID-19 from March 13th, 2020. We got guidance from the National Oral Health Lead to reduce our service to essential or emergency only. And access to DGA across the HSE was extremely limited during 2020. So the impact of COVID-19 on people with disabilities was enormous. These people had huge challenges dealing with the public health restrictions of social distancing, hand hygiene and mask wearing, and many people were cocooning due to their own health issues. Restricted access to dental teams to care homes was huge, and concerns of carers trying to provide oral care was also an issue. So it resulted in the oral health of these people being largely unmonitored. And if an oral health issue did present, it was extremely challenging to manage that. So this involved arranging access to the patient for an examination by a dentist, and if a DGA was needed, either placing them on a waiting list or trying to fast track access at the nearest centre, and then coordinating COVID swabs as well. So it was extremely difficult to organise and manage oral health issues as they presented. So for all of these reasons, COVID-19 was seen as the biggest challenge ever faced by special care dentistry. So the aim of my MDPH project really was to describe the effect of COVID-19 restrictions on access to DGA by comparing data 1 year pre-COVID to first year COVID in 2 regional centres outlined there in the map of Ireland. You can see Connolly Hospital in Blanchardstown, Dublin, and which takes referrals from Dublin, Kildare and Wicklow, and also Mallow General Hospital, County Cork, taking referrals from Cork, Kerry and South Tipperary. So these are 2 very different centres. One is very urban and one is quite rural, and they take the catchment areas involved. It would be about 58% of the population of Ireland, so they're quite busy centres. So if you can move to the next slide, please. So moving to the materials and methods section, thank you. The timeline shows the access of DGA during the first year of COVID. So wave 1 arrived and it resulted in essential access only, with restrictions with DGA restrictions. So these were lifted on the 18th of May for general services. Connolly Hospital restarted its DGA on the 28th of July, followed by Mallow on the 24th of September. So during wave 2, services were just started and they continued. Wave 3 arrived and it brought a break in services to DGA in both after Christmas in both Mallow, which restarted on the 25th of February, and Mallow started then, and then Connolly started on the 13th of April. So it had an impact with breakages. So the study is a retrospective chart review. The purpose of the sample was derived from the attendance at DGA over the 2 years in Connolly and Mallow, which received referrals from 8 different dental areas in 5 community healthcare areas. So ethics approval was granted from the Clinical Research Ethics Committee of the Cork Teaching Hospital. Soul Health is the HSE Public Dental Service National Record Management System, and permissions had to be granted from 5 of the heads of primary care, and conversations with the 8 principal dental surgeons whose areas provide the referrals to the centres. So I also had to discuss the project with the data protection officer in relation to retrospective, in relation to the consent issues. But fears around these consent issues were addressed in specific guidance in relation to retrospective chart reviews, and it was outlined in an amendment to the Health Research Regulations Act, which was published in January 21. So I was very fortunate that it was able to allay all fears around consent, because I was following a very detailed process of anonymising the data and complying with all regulations in relation to GDPR. So I designed a very simple Excel spreadsheet, and I included variables which were available within the Soul Health system and which were indicated as significant in the literature which I reviewed. I piloted this, made a few adjustments, and then proceeded to data collection. The demographic and clinical data were retrieved and were irrevocably anonymised and uploaded into the IBS SBS version 27 software. So you can move to the next slide, please. Moving on to the results. Okay, so the sample was 212 people who accessed DGA in Connolly and Mallow. The Connolly service accounted for 119 individuals, which was 56% of the sample, and 93 individuals accessed in Mallow, which was 44% of the sample. So the results in figure 4 show the gender distribution. Overall, 56% male and 44% female within the age categories. And this slight male majority is often reflected in studies of this nature. The mean age of the sample, mean age was 37 and median age of 35 for Connolly. The mean age in Mallow was 38 and the median age was also 38. So the effect of COVID restrictions is demonstrated by a reduction in the number of appointments to DGA for patients attending Connolly, being 63% reduction, and Mallow showed a 73% reduction, which you can see there in table 1. There's also an increase in waiting time from 6 months to 12 months approximately, which you can see in table 2. So I also recorded the original reason for referral, which was the reason that was cited at the time the patient was placed on the DGA waiting list. As you can see there in table 3, the review appointments were responsible for 65% of DGA referrals on table 3. So moving to the conclusions. So the impact of COVID restrictions on DGA in both centres resulted in a doubling of waiting time from 6 months to 12 months. This is a very significant waiting time for patients who are experiencing pain, swelling or trauma, or who may have pain originating from any other dental issue which was noted at the time of referral. Restrictions around COVID meant reduced access to review appointments, and we're well aware now that 65% of the DGA referrals originated from a review appointment. So we're aware that people did not receive these appointments during first year COVID and did not access the preventive treatments and oral care from visiting dental teams. And this may further increase the risk of poor oral health outcomes for these people and increase the need for DGA and IV sedation. So from the demographic data and the mean and median age of both groups, we know that this is largely a young population and that it's reducing their chances of a lifetime of oral health. So I've included a direct quote from a patient record. "If he's in pain, no one in our house is safe." And I think this is very profound. I think the unmet treatment need of each individual who is waiting for DGA in Connolly and Mallow Hospital due to the reduced access during COVID is really an identifiable risk. This is the risk to their oral health and general health, but it must also be remembered that each person lives with a family member or with co-residents, and it must be extremely difficult for those communities to manage these risks. So moving to my recommendations, firstly, access to DGA must be prioritised at all time for people with disabilities. We must have strategies to reduce the reliance on DGA. including making targeted individualised oral health promotion for people and creating supportive environments in the care facilities, training staff in oral home care, and in having a multi-layered approach to mainstreaming oral health in all policies in residential centres. So we must develop our dental services as well to prioritise staff training, ensuring equity of access to additional treatment modalities, including IV sedation, through appropriately trained clinicians throughout our service. We also need necessary training on improving quality of data entry to ensure that our soul health can be used to facilitate ongoing studies going forward. So I'd just like to conclude by quoting the recent press release by the World Health Assembly. In future pandemics, we really need to strengthen the global health architecture to promote the well-being of all people. And really, this very much includes vulnerable people with disabilities who need a strengthened access to DGA. Oral health is a basic human right. It's an integral element of health and well-being. Thank you for your attention.
Thank you, Myra. I understand that the chat isn't visible to everybody. So if people have got questions for Myra and you want to put your hands up and put your screens on to ask a question, that's fine too, because we're not an enormous band of people. So has anyone got a question? Any hands up? I mean, my question really would be, and I would ask this particularly, well, everybody taking part today, with hindsight, is there anything you would have done differently? Having lived through all this.
Having lived through all, I did find when I was collecting the data, that there is a wealth of qualitative information that I would love to have collected. You know, I just lifted one point out because it was really in the qualitative information that you got the full impact of what I was going through. And I had to be very disciplined to just stay looking at what I needed to look at. But I do think that it would have been great to also have had a qualitative track to the research, but obviously time wasn't on my side and one person couldn't really accomplish it all. But yeah, I would like to have recorded some of that.
Yeah, you just have to do the best that you can in the situation and as it unfolds. But all of these things are a learning experience and keep learning every day.
Absolutely.
Yeah. Anyone else have a question for Myra? Charlotte. Charlotte, do you want to put your camera on and ask your question? Go on, Charlotte. Thank you.
Yeah, it's not really a question. It's more of an observation. And I was listening to your presentation, and the thing that struck me was the quote that you had that said, if he's in pain, the rest of us in the house aren't safe, or something like that. And it really made me sort of prick up my ears and think, oh goodness. And I think we forget, don't we? Because we're so focused on the oral health, but actually, when we think about it, of course, that makes perfect sense. But day to day, you forget that. And I think that quote actually is really powerful. And I don't know, maybe that's the sort of thing that we need to think about a bit more, don't we? And we can perhaps use that quote to highlight quite how important being pain-free is for some groups in our society. It was just really made me sort of sit up and take notice. So I think, you know, the fact that was highlighted was really good.
Yeah, it really did strike me as I was going through it. I just said, I can't not. It really makes you think. They're not numbers. These are individual patients, and they have such a hard time. I suppose the health inequalities they suffer at the get-go, and then compounding that with restricting their access to DGA is it's not acceptable.
No, it's not. And of course, we're not disadvantaged in just the individual, are we? That you know, the quote showed us that it's the care package, it's the family, it's everybody, isn't it, that are disadvantaged by, you know, those restrictions for whatever reasons. Yeah, really powerful quote.
Thank you. Yeah, I thought so too.
Thanks for that, Charlotte. I thought that too. And just to say that Charlotte is BASCD Council, a member of BASCD Council, and she's our lead for health improvement, oral health improvement. So thanks for that. So have anyone got any more questions, or are we ready to move on?
Okay, that's great. Thank you.
Thanks very much, Myra.
Thank you.
Our next poster presentation is going to be presented by Rachel England. And Rachel, are you able to share? Have you got facilities to share?
I do.
Yeah, that's good.
Thank you.
That's happening by magic, I think. So Rachel's poster is entitled Oral Health Under the Clouds of COVID-19. So the floor is open to Rachel now, and then we'll have some questions.
Thank you.
Okay.
Thank you so much for inviting me today. You know, I'm absolutely delighted to be here. A huge thank you to BASCD and the Borough Foundation as well for supporting this initiative. Also a thank you to my supervisors, Professor Vida Sohori, I know she's here today, and Dr. Lawrence Nyanzi. So through my research, I really wanted to understand how oral health and oral health habits had been affected among residents in Teesside, and also how the dental clinic closures had affected these communities. If you don't know it, Teesside is a region in the northeast of England. It's made up of 5 boroughs, and within those boroughs they have among the highest levels of deprivation in the UK, and also some of the poorest health outcomes. So this region has higher than average levels of cardiovascular disease, diabetes, chronic lung conditions, and also 20% of the population smoke, and they have above average a number of people admitted to hospital for alcohol-related injuries. So I'm sure it'd be no surprise to you to understand that this area also has among the poorest oral health outcomes in the UK. Caries affects on average 25% of children by the age of 5. It's the highest in Middlesbrough at 39% and the lowest in Hartlepool at 15%, and that's thanks to water fluoridation in this area. Before the pandemic, only 53 and 83% of the population had been for a dental checkup within the last 2 years. And this region also has above the national average rates of oral cancer in men, and unfortunately some of the highest mortality due to oral cancer as well. So through my research, I took a quantitative approach. My ethical approval was gained from Teesside University School Research Committee. My survey was based on the World Health Organization Adult Oral Health Survey, which is a survey used globally to collect oral health data. I adapted the questions slightly to understand how oral health behaviours had changed before and during the pandemic, and did a small pilot study in the region with 10 to 15 people. The survey was open for 18 months from March to June 2021 and open to adults aged over 18. Even a year after the start of the pandemic, we were really still seeing issues with the pandemic. Community centres were closed, all social care appointments were being done online still, so I really had challenges with recruiting participants to this survey. And that's why I decided to take a social media approach. So I approached people with a large Facebook community Teesside group admins and asked them if they would share the survey within their groups. And I also approached people in Teesside with a large Twitter following and community groups. And I also liaised with Healthwatch, who in their local regions in Stockton, Teesside and Middlesbrough shared the survey as well. Through this approach, I received 203 responses. Of those, nearly 90% were female, and nearly 90% of those were white ethnicity. Almost 70% were aged under 50, and their annual income was less than $30,000 a year. Their educational attainment, nearly 70% of the respondents had at least an undergraduate or postgraduate education. So this was quite an educated cohort of respondents. The first set of questions, I wanted to understand people's oral hygiene habits. And when we analysed the data, it was quite obvious that people aged under 30 had been the most severely impacted by the lockdown, and their twice daily toothbrushing decreased by 14%. We also noticed that incidental cleaning decreased by an average of 4% across all age groups. And we noticed people brushing just 2 to 3 times a week increased in all age groups as well. So I asked people how they felt about their oral health. Your self-rated oral health is quite a good indicator of oral health related quality of life. 45% of people told me that they felt their oral health was average. But when we looked at oral health compared to income level, it was quite obvious that the people in the lowest income categories were more likely to rate their oral health as poor compared to those in the highest income categories. Following on from that section, we talked about self-rated oral health and how people felt the lockdown had affected their oral health. Almost 40% of people felt that the lockdown had a negative impact on their oral health. And then we looked at dental clinic closure. So before the pandemic, 85% of people were living without any kind of dental pain, but this decreased to 65% during the pandemic. 35% of the people that had experienced dental pain, I asked them how severe it was, what kind of problems they'd had. 35% said they had pain. Of these, 12% had a moderate level of pain, and most worryingly, 9% had severe dental pain. Before the pandemic, this cohort, fewer than 50% had attended the dentist within the last 12 months, so we had quite a low dental attendance before the pandemic. So I asked them if they tried to access a dentist during the pandemic, if they'd had dental pain, and 21% had tried to access the dentist but were not able to do so. And 10%, most worryingly, resorted to DIY dentistry. And in my final thesis, I've taken a mixed methods approach, so I really took a deep look into this with the qualitative aspect. So in conclusion, we know that the COVID-19 lockdown had a really severe impact on this cohort. Their self-rated oral health was really poor. We noticed a decline in their self-care routines. So we can only imagine the impact that it had on the people in the lower socioeconomic groups and the groups that are hard to reach, like the elderly or BAME communities. And we know that pre-pandemic, this cohort had a poor dental attendance, and now through the media, we know that there's an even more scarcity of dental appointments. We have 30 million missed appointments according to the press. So we can only imagine the high levels of dental pain and disease that people in this region are suffering at the moment. For my recommendations, I think it's really important for us as oral health professionals and public health professionals to work closely with policymakers to advocate for increased funding for NHS services, which are desperately needed, but ensure as well that this access is equitably distributed in high needs areas. We need increased research in different socioeconomic groups to understand the wider impact across the UK, and most importantly, focus on dental prevention and really integrating oral health care into non-communicable disease strategies. And we need to be prepared for the next pandemic. We do know that it will happen again, hopefully not in our lifetimes, but we need to be prepared to ensure that dental practices don't need to close for such a significant period of time. It was unprecedented for dental clinics to close for 3 months. And although there were urgent oral healthcare centres in Teesside, there were only 18 available for the whole community. And these were signposted through 111 services, so people didn't really know how to access those emergency hubs. I'd just like to say again a huge thank you for being here today, and please, if anybody has any questions, I'd be delighted to answer them.
Thank you very much, Rachel. So well done on presenting your poster. Has anyone got any questions for Rachel? Well, I'm going to start off, Rachel. So what do you think we need to do now? Oh, we just lost Rachel. There she is.
I'm back, sorry.
What do you think, as a result of your work, what do you think we need to do now? I know you were saying, what's the most pressing thing we need to do?
I think it's really making sure people have access to care. I'm still in the Teesside community groups, so I'm really, still seeing the messages that people are sharing. They're all desperately looking for a dentist. You see every single day people saying, I'm in terrible pain. Does anybody know an NHS dentist that's taken on patients? And there's just absolutely nobody that can see these people. So I think we really need to urgently figure out how we can get care to these communities.
The reason I ask it, Margaret and I were having a little preparatory meeting this morning, and we both commented on the fact on BBC Wales, it was first thing on the Welsh News this morning about the backlog and the fact that even people that are usually accessing dentistry aren't getting to it. But so thank you very much for that. Has anyone else got any? Margaret.
Yeah, Rachel, that was an excellent presentation. Thank you very, very much. And you've got clear recommendations. I just wonder, do you have any idea how you might be able to put those on people's agendas? recommendations to change policy and strategy?
I think it's quite challenging at the moment. There's quite a strong patient advocacy group that's been set up that are called Toothless in England. I think it's important to work with patient advocacy groups because, you know, they do have the power to make change. I think it's important to work with advocacy groups like Health Watch UK. They've been very proactive in advocating for improved services and commissioning for NHS dentistry, and also to share research and findings with the local commissioning services so that they have more of an idea. Well, I'm sure they have a huge idea, but you know, they have the data behind them to understand the impact on their communities, and so that they can be advocating at a higher level for increased funding to their commission services.
Thank you.
You're welcome.
Thank you. I keep forgetting to unmute myself. So thanks very much, Rachel. Any more questions? Okie dokie. Well, I think you're saved by the bell there, Rachel. So I think we're going to move on to our next presenter, next poster. And this is going to be presented by Ross Keat. And his poster is The Effect of National Lockdown on NHS Orthodontic and Referral Patterns. So Ross, if I can hand the floor over to you.
Thank you very much.
Welcome.
Just checking that this is going to work, okay. I think I need to do a couple of things. I need to, give me 2 seconds. If I do that.
It's fine, Ross.
Can you, am I now big on everybody's screen? Brilliant. Okay, and now hopefully this should work.
Go for it. Oh.
Brilliant. So, has everyone got that on the screen? Yes?
We have you, Ross.
Do we have, is there some animation on the,
Yeah.
There is.
Prezi video.
Prezi.
There we go. So that's good. So thank you very much. So this is my presentation today, and it's referring to the effect of national lockdown on NHS orthodontic referral patterns. It's important to note that this is specifically within England. So a quick introduction. The coronavirus pandemic has created novel barriers to both providing and accessing all forms of healthcare, and this includes dentistry. And there's been some very rapid changes made very early in the pandemic to protect both providers and users of healthcare services. These changes have impacted on the accessibility of all healthcare services, and again, this includes dentistry. So, to see how much access to specialist services were impacted, I have had a look at referrals from general dental practitioners for orthodontic treatment across 2 time-matched periods, either side of the first UK-wide COVID lockdown. And also during this, I had a look at the IMD, the indices of multiple deprivation, for those who were referred. Now, this is an interrupted time series study. So the pre-COVID period was July to December in 2019. Obviously, the intervention then was the COVID lockdown, and the post-COVID period was July to December in 2020, when dental services had resumed. I'm going to be looking at some data, and there was a null hypothesis within the study that there was no statistically significant difference between referral numbers between pre and post-COVID. And we can also look at referrals as a proxy for primary care access. So ultimately, if there are fewer people attending a dentist, fewer people are going to be referred on to access specialist services. We can also use this data to better understand the impact of COVID on the need, supply and demand for specialist orthodontic services. So we can view across the whole of dentistry from generalist services to specialist services. And from the perspective of myself as a public health practitioner, it's important to see how COVID has impacted on the delivery of these specialist services, as this helps me better understand how I might advocate for clinical colleagues during our recovery. So moving on, just a few quick points to consider throughout this presentation. Firstly, as we all know, the National Health Service is the publicly funded healthcare system within the United Kingdom, and it's almost entirely subsidised by general taxation and national insurance contributions. Now, within this paradigm, dentistry is quite interesting, as alongside pharmacy, prescriptions and optometry services, it is one of only 3 NHS services which attracts a fee for a majority of adult service users. The taxable income accounts for 98.9% of all NHS income. So dentistry, optometry and pharmacy services make up the remaining 1.1% of NHS funding. And of these 3, dentistry is the single largest input to that 1.1%. I'm talking about orthodontics a lot. What is orthodontics? Well, it's a dental specialty that addresses diagnosis, prevention and correction of malpositioned teeth and jaws and misaligned bite patterns. It's one of the GDC registrable specialties, and typically an individual will undergo 3 years of specialty training to become registered as a specialist orthodontist. We also have to consider that a majority of NHS orthodontic patients are children. Now, this is important because it will not normally be the children themselves who are demanding access to care. It will normally be parents or carers. We should also note that there are a very, very small amount of adults who will access NHS orthodontic services, and this may be because of severe malocclusions to the jaw which require intervention, or because they've been on a waiting list for such a long period of time that they've actually become adults. But as long as they're on the waiting list whilst they're a child, they'll still receive treatment. And finally, let's consider IMD. So indices of multiple deprivation, we talk about it a lot. What exactly does it mean? Well, it's important to understand that it's a relative measure of deprivation. So that means that in order to calculate the IMD, there's a basket of 37 metrics which are considered. So for example, these will look at how many teachers there are per 10,000 children and the educational attainment level of parents within a region. These are all then ranked against each other. So the IMD is then done on a relative level. So from all these scores, all the regions in the bottom 10% will become IMD1. The second 10% will be IMD2, up to the area which scores the highest across these 37 metrics, which will be IMD10, which indicates that it has the lowest level of relative deprivation. So a little bit of background to the COVID lockdown and what happened. So on the 23rd of March 2020, the Prime Minister instigated a nationwide lockdown across England, and rules were introduced to curb COVID transmission. And 2 days later, on March the 25th, the CDO advised that both NHS and independent dental providers should terminate all routine dental services. During this time, urgent and emergency care was prioritised for all face-to-face appointments, and all other issues were managed remotely. This remained the norm until the CDO advocated for a transition to recovery on the 28th of May 2020, stating that all routine dental services should resume from the 8th of June 2020. It was advised that service provision was based on urgency of need, particularly for marginalised groups, which is very important within the context of this presentation. Modifications to service provision in both generalist and specialist care resulted in barriers to service delivery. For example, fallow periods were introduced, which reduced clinical estate, and enhanced PPE had to be worn, which meant that clinical time was affected as clinicians had to don and doff different equipment. So let's have a quick look here. As I've already touched on, this is an interrupted time series. There was a period of time, an intervention, and then a second time-matched period. So to be included within the study, regions which I have looked at had to utilise a specific locally commissioned electronic referral service, and this is called FDS Consultants. And this had to be active for orthodontic referrals in both the entirety of the pre and post-COVID time periods. The patient's postcode also had to be in England. Now, this is because we've considered indices of multiple deprivation, and different devolved nations have different metrics for IMD. And then, as I've touched on, there's a null hypothesis, which requires some statistical analysis. Now, a paired t-test was chosen as the values included best conform to the assumptions required for this particular test. So we have a look at the results by time from July to December. Here we can see the absolute numbers of referrals made from general dental practitioners to orthodontic services in 2019 and 2020, and the percentage of the total referrals as a breakdown. Now, we'd be expecting to see that referrals, we'd expect them to drop, but we'd hope that the percentage of total referrals might remain the same across the two time periods. Now, I understand it's a little bit difficult to maybe understand what's going on just looking at the numbers, so here's a graph instead. And as we can see, July, August, September, there are significantly lower numbers of referrals in 2020 compared to 2019. And then things start to pick up in October, November and December. And in December, the 2020 referrals are roughly 50% of the 2019 referrals. Here we can see in a very wordy way, though, that there is a statistically significant decrease in the referral volume from 2019 to 2020. If we have a look at the results by indices of multiple deprivation, here we can see that IMD decile 1 is the lowest, IMD decile 10 is the highest, and we can see the overall number of referrals. So again, the left column will all add up to 44,166, and the right column of 2020 will all add up to 14,964. And we can see the percentage of the sample as well. Now, we'd expect and hope to see that the pattern would be the same across the 2 years, which would indicate that no particular group has been disproportionately affected by the COVID pandemic. So if we consider this as a percentage of the total sample, we can see that IMD1 has suffered quite a significant drop in terms of the percentage of total referrals, whereas IMD10 has had quite a significant increase in the number of in the percentage number of referrals made, which means that there's been a disproportionate impact of lockdown and the changes made during lockdown on the most deprived groups in society. So let's talk about this a little bit. So across the 2 time periods, referrals have demonstrated a statistically significant decrease from 44,166 in 2019 to 14,964 in 2020. And there's some evidence that in medical specialties that this may be due to an altered perception towards healthcare need amongst patients and clinicians as a result of the COVID pandemic. Now, in 2019, 15.23% of all referrals were sent from those in IMD1, which is those occupying relatively the lowest socioeconomic position. And this fell to 19.96 in 2020. So in 2019, this was the single largest group referred, and in 2020, it was the 4th largest decile by percentage of overall numbers. And IMD10 was the 2nd most referred in 2019 with 11.57%, but this rate rose to 16.21% in 2020, which made it the single largest group referred by IMD. So just to remind you what that looks like. Now, this indicates that there's a potential post-COVID inequity in specialist orthodontic care access. When we consider why this might be, it's important to remember that a majority of patients are children, and the IMD assigned to the orthodontic referral is associated with where the parents or carers may live. We know that those from IMD 10 tend to be better educated and better equipped to navigate complex healthcare structures. They're often more healthcare literate and less fatalistic than those from lower socioeconomic positions. Additionally, we're also aware that COVID caused increased stresses on families from lower socioeconomic positions, and these individuals are more likely to be affected by losing jobs, furlough, and decreased incomes. Now, if we consider this, and it's the parents who are actually demanding healthcare access, this may reduce the perceived importance of accessing healthcare for orthodontic need, and it might not be seen as important as other issues. So, if we look forward, we can see that there's this large decrease means that there's potentially large numbers of unmet demand within the population. And this simplistic modelling is simply done by minusing the 2020 referral from the 2019 referral and then adding that number to the 2019 referral number, which shows the shortfall added to what we'd expect from a normal year. So, to conclude, there is a significant reduction in orthodontic referrals from 2019 to 2020, but there is no evidence in any healthcare literature for any reduced normative need, and indeed any reduced normative dental need. So we still assume that the same need is there within the population. There also needs to be clear strategies developed to empower and improve access for deprived groups, as despite what the CDO requested, marginalised groups seem to have been the most impacted by the changes from the COVID-19 pandemic. And most importantly, there are potentially large numbers of individuals who have not yet demanded care, indicating that the recovery from the COVID-19 pandemic could be extremely complex. Thank you very much for listening. Here's a list of my references, and I was wondering if anybody had any questions.
Thank you very much, Ross. Thank you. Sometimes I have to say I've felt like that cat on the keyboard. So having had a career that focused on a lot of data analysis, because I was counting teeth in Wales quite a bit, that made me smile. Does anyone have any questions for Ross? If you do, and you think of any, please put up your hand and I'll pull you in. I have a question for you, Ross, in terms of which of your public health skills do you think you were able to utilise the most, to best effect doing this piece of work?
I mean, it's clearly a healthcare public health piece of work, looking at systems and how we improve systems, and also using a lot of big data. So in terms of how this project worked, I mean, there wasn't so much engagement with other healthcare providers, but I did have to do a lot of analysis of data. I did have to consider why the data looked like it did, and also have tangible reasons for why that data might take that appearance. I think often with big data, we look at things and we try and make inferences from patterns which might not actually be true. So I would say that it was the analysis and the utilising healthcare public health skills which really helped me to put together this piece of work. Right?
Yeah, great. I thought you'd say that. I guessed you might say that. I've noticed, Charlotte, you've got your hand up. So Charlotte, would you like to put your camera on and ask Ross a question?
Yeah, sure. Thanks for that, Ross. I really enjoyed the little animations. I thought that was excellent. That was really good.
There's been a lot of death by PowerPoint recently, so I thought I'd try something a little different.
Yeah, it was good. It was good. I liked it. I just wanted to ask, because I was thinking about your presentation, and I was also thinking about Rachel's beforehand, that sort of was intimating at similar kinds of things. How do you think, or do you have any ideas about how we can get over this? Not how we can necessarily clear the COVID backlog, but how we can get over the pattern of, you know, inverse care, you know, the people in the greatest need not coming forward and accessing the care. That's the crux of it. Otherwise, we're just going to keep repeating that, aren't we?
Yes, I agree, and I think that we have to look at ourselves as individuals who can leverage change in those ways. Even the sort of turn of phrase, hard to reach groups, grinds my gears a little bit. The group isn't hard to reach, the service is. So I think it's all to do with community engagement, making sure that we're engaging with the right people in those communities and delivering messages in a way which is appropriate for those individuals. It's all well and good delivering a nice glossy leaflet about the importance of orthodontic care, but if that falls into the hands of somebody who maybe isn't a native English speaker or can't read or doesn't want to read it, that message isn't going to be passed on. So it's about, I think, utilising community assets to engage with these groups that we know are struggle to access the services which we offer.
Yeah, I would agree. Definitely an assets-based approach for sure. And I think if we could crack this, we'd all be out of a job, wouldn't we? Because everybody would have great oral health. Thank you very much.
Thank you.
Do we have any more questions for Ross? Thanks, Charlotte. Kate, right. Kate, would you like to ask a question?
Thanks very much, Ross. That was really interesting. I think you mentioned something about there was no evidence of a change of need in the literature, and I didn't know whether that was post-COVID or as an impact of COVID, or whether that was in terms of deprivation across the profile of the population.
So I couldn't find any evidence that there would be any reason for decreased normative need across all of healthcare specialties. So no medical literature said COVID has caused changes which are going to reduce the normative healthcare needs of the population. So
Okay, and what about then in terms of the need for orthodontic across the deprivation deciles? Is that the same, or is there any evidence for that?
I couldn't find any evidence that that the changes from COVID would impact on the need for orthodontic treatment across the deciles.
Sorry, not for COVID, because of COVID, just in general. And I'm just wondering if there's a pattern.
In terms of, well, so I'm not aware of any pattern which has impacted on who may or may not need orthodontic treatment. I mean, we're aware that those from lower indices of multiple deprivation, so higher socioeconomic position, are more likely to access specifically orthodontic services because of this increased perception of need for perfect aesthetics, and it's often the parents which are driving the need for that access and not the children. So you speak to the children, they'll say, it doesn't bother me that this tooth's slightly crooked, but it's the parents who might request that to be corrected. And that parental drive and understanding of how to navigate the healthcare system is greater from those in a higher socioeconomic position than a lower socioeconomic position. But ultimately, whether you're from IMD 10 or IMD 1, you're still at the same risk of having a misaligned bite. It's just how it's perceived by the parents and carers of these individuals.
Okay, thank you, Ross.
Thank you, and thank you, Kate. And Kate's on our council, and she is one of our epidemiology leads, the lead for the service side of things. So thanks, Kate. So have we any more questions? I think what we'll do now, thank you very much, Ross, for your presentation and for fielding questions. We'll move on to our final poster presentation, which is to be given by Anna Bevan, and her poster is on oral surgery provision in the North East and Cumbria. So Anna, if you'd like to take the floor, I'll mute mine.
Sure. How do I present my poster? Do I share my
right.
screen?
Share your screen, yeah. So there's a little square with an arrow if you
let's have a look.
On the top usually. Yeah. There we go.
Okay, can you see it? Can you see it?
Yeah, we can see it, yes.
Okay, great.
You might want to focus in a bit, on sections a little bit so people can see it. Yeah.
Great. So hi everyone, welcome to my poster presentation. So this poster is about a service evaluation that we conducted in the northeast of England and North Cumbria to assess how oral surgery services were impacted during the pandemic. So I'll start by describing the background of our project a little bit. So back in 2015, NHS England published the Guide for Commissioning Oral Surgery and Oral Medicine. This was where oral surgery procedures were classified into levels 1, 2, and 3, meaning that different complexities of treatment could be carried out by clinicians with varying experience in different settings. So what this meant was that not all patients requiring more complex oral surgery needed to be seen by a specialist or in hospital. When the pandemic hit, both general dentistry and oral surgery services ceased to operate. And despite there being the range of tier 1, 2, and 3 services existing for oral surgery in our region, there was no centralised referral service or record showing who is provided what care and where and everything like that. So this led us to carry out a service evaluation to determine who provided which treatment where in the region, and following on from this, how the pandemic may have affected the provision of treatment for different providers at different levels. So as well as evaluating how the services were affected, we also wanted to identify how these services had adapted to the pandemic, both during the pandemic, but also in the future. So moving on to the methods. I created a survey which was to be sent to all level 2 and 3 providers in the region. So these were people carrying out more complex oral surgery than your general dentists. So there were several questions that determined the type of service and the type of clinicians working in each unit. And then I asked 2 specific COVID related questions. So these were, how has your service been impacted by COVID? And how do you see your service changing as a result of COVID? Participants could respond in free text. And that was how we collected the information. But in order to send this out, we needed to find out who the oral surgery providers were. So the first thing we did was that we contacted the commissioners to provide a list of practices and hospitals who held an oral surgery contract beyond the general dental services contract. Then we discussed with local oral surgery and oral and maxillofacial surgery clinicians for further details as to who's providing oral surgery in the region, because the list didn't have all of the providers on it. So I had this amalgamated list with telephone and email numbers and contact addresses. And I sent out the survey via NHS email with options for providers to either respond by email or post, and everyone that responded emailed me. I carried out some follow-up emails and telephone calls from January to August. We got 6 responses overall, which was about 40% of the providers. And I'll scroll down to the bottom left of the poster. So you can see in green, these are the people that responded. So we had a bit of an overrepresentation of those within Cumbria and the southern part of the northeast compared to the central part of the northeast, which is the more densely populated part. So now we'll move on to the results of the study. So out of the 6 people responding, 100% had a decrease in capacity for service provision, and 5 out of the 6 hadn't caught up yet with the pre-COVID activity levels. And there were a few factors affecting this. So the first was fallow time. So this is the period which allows for droplets to settle onto surfaces after carrying out an aerosol generating procedure, which is otherwise known as AGP. So when the droplets have settled, you can then decontaminate the surface. So during oral surgery procedures, if there was a surgical extraction which required bone removal with a drill or a handpiece, this was an AGP. Providers also reported, as well as having to space appointments out to allow for this fallow time, they also changed their appointment times so that patients wouldn't be congregating in the waiting room. So this reduced how many patients could be seen over a clinical session. Another factor was PPE. So providers in primary care reported that there was a high cost of PPE and it was less readily available as well. So the Office of the Chief Dental Officer changed the guidelines for PPE. So everybody had to wear a filtering face piece mask, which is an FFP3, if they were carrying out an aerosol generating procedure. Some providers simply could not carry out enough surgical procedures because they couldn't afford the PPE or there wasn't enough stock for PPE. PPE was prioritised to practices and oral surgery sites who became urgent care centres. So any oral surgery provider who was not an urgent care centre was mainly just acting as a triage service where they would provide advice, analgesics and antibiotics, and then they would refer to an urgent care centre as required. So PPE was another factor affecting capacity for treatment and service provision. The third way that services were impacted was changes in the workforce. So 2 of the people that responded to our survey were from primary care oral surgery sites who became urgent care centres. So the oral surgeons working at these centres were heavily involved in triage. Some patients wouldn't be seen at these urgent care centres and they might be redirected to other sites, such as the dental hospital, which was a hot site and could provide care for patients that were COVID positive. Both clinicians and support staff were also not always available because they either contracted coronavirus or had to isolate because someone in their household might have had coronavirus or symptoms. So moving on to the discussion now. So there were several pointers to discuss based on the survey. The first is that when the pandemic hit, there was no centralised list of regional or national oral surgery services. A centralised list could have improved the efficiency of PPE distribution, staff redeployment, and potentially reduce patient delays in accessing to care by streamlining the referral pathways. A positive thing that came out of the pandemic was that a lot of primary care providers didn't have an NHS email, which limited the speed and quality of information that could be shared, such as radiographs, which are better sent digitally. So the provision of the NHS emails improved the effectiveness of the referrals process, not just during the pandemic, but also in future. In the long term, clinicians could benefit from having an NHS email. There were some limitations to my study. So firstly, the list from the commissioning team of oral surgery providers had a lot of practices, but many of these were only providing level 1 care rather than level 2 or 3 care. When the list was changed to include secondary care sites, some of the practicing sites were still not included, which was concerning for us. We also had a low response rate, and there was a bias towards primary care providers whose needs and ways of adapting to COVID may have been different to hospital providers. We could glean a lot of useful information from the respondents who did complete the survey. So 5 of the 6 respondents were still working at reduced capacity and had long waiting lists, but they had some suggestions on how to address this. So this included increased funding to manage the greater caseload, so providers would be appropriately remunerated for doing extra work. Some providers suggested setting up extra clinics, including weekends, and the option for assessments or discussions to be carried out via telephone or video call to reduce the number of face-to-face appointments needed to access care. One of the providers also suggested that there will be a greater need for treatment in oral surgery in years to come, this being a consequence of general dentistry being less accessible through the pandemic, which is something that could be studied further in the future. So overall, our project shows how services can be drastically affected by the pandemic, but providers can find creative ways to adapt to the rapidly changing situation. Having more clear information as to the oral surgery services available, not just in the region, but also nationally, could be an effective way to improve capacity for care, not just during times of crisis, but also in the long term. The clinicians who responded to the questionnaire suggested helpful and practical ways to address the backlog of patients waiting for treatment during the pandemic. This may be of value to commissioners and managers of the services to improve access to care for patients needing oral surgery in the future. That's everything. Thank you for listening.
Thank you very much, Anna.
Thanks.
That's lovely. So have we any questions for Anna? So I have we have a question. Yeah, Yvonne. Yvonne, would you like to ask your question?
Thanks, Maria. Thanks,
you.
Anna. That was really, really informative and something we've all been struggling with in various areas across the pandemic. And you just touched then towards the end on capacity. And if I may, Maria, just ask Anna, perhaps slightly outside of what she's just presented, whether you've got any golden nuggets to help us all while we're struggling with looking at increasing that capacity, because oral surgery, as you know, is a problematic area. It's actually on some of our goal command lists. And whilst we look at increasing capacity, there is a need for those with the more complex care to access service. So if I may, it's not actually the presentation, but I'd be really interested if there's any golden nuggets that you could give us from that. Thank you.
I feel that the suggestions that the providers had, there could perhaps be meetings set up, perhaps maybe with the dental networks or things like that, where these kind of practical solutions could be offered, and then kind of more discussion between the commissioning and management side to sort of find creative solutions. That could be a way. I think as well, maybe the patient perspective could also be included, because I think access to oral surgery will affect people in different ways, and patients might have solutions that maybe clinicians and managers might not have thought about as well.
Thank you, fabulous.
Thanks, Yvonne. I think Mairead had a hand up. Mairead, would you like to ask a question?
Yeah. Thank you, Anna. It was a lovely piece of work, and I suppose my question is similar to Yvonne's, and it's looking at, you know, you've been able to document and show the challenges that we've all been living through. So again, that point around a centralized list and being able to, you know, you sort of think it's so obvious, but it took the pandemic to say, okay, we've got to sort of organize who's actually delivering these services. Were you able to contribute or make suggestions towards that centralized list? Or
well, I have my own centralized list now, but I haven't put it forward just yet. But I have been kind of, as I've been going along, I was updating the commissioners as to who was and wasn't currently just kind of correcting the information on the list and saying these people aren't doing level 2. These people, some people had, for example, a historical contract, and that's why they were on the list. So I kind of did update, but I can probably send them my complete list now. Yeah.
Thank you very much. Thank you.
Thank you, Mairead. And just to say, Mairead's on council, and Mairead is our president designate and will be president the year after next. So thanks for coming on board, Mairead.
Not at all. Thanks, Maria. And I look
Thank
forward
you.
to seeing people in Ireland, all being well.
Yes. So Charlotte, would you like to ask a question?
I would, yeah, sorry. I'm always one for questions. I thought that was really interesting, actually. In fact, all the presentations have been really good. But I'm sort of leading on from Mairead's comment and question, actually, because that was the bit that I picked up on mostly. And you answered around, how you've been updating the commissioners with the centralised list. But I think Mairead's point is right. It's taken this pandemic for us to realise these really quite basic things. And you had some really nice, clear, straightforward, fairly easy to implement recommendations, it seemed to me. The list, the emails, they're quite straightforward and kind of makes you think, why have we not been doing this? But I was wondering, do you have any plans for how you can sort of operationalize or get people on board to disseminate the information to operationalize these clear recommendations, because they seemed really concrete, really simple, and really specific and clear?
I suppose I don't have any straight plans at the moment, but with the oral surgery consultant that I'm working with. I think she knows a lot of the surgeons in our local network, and I think I would. The service evaluation also had some other questions that we were exploring. So I think once all of those results are together, we would probably put it all together and then present it to the oral surgery network. That would be a way to kind of amalgamate everything. Yeah,
I just think because they're so simple and they're so specific and so clear and could make a huge difference, but other situations where we need to communicate with NHS dentists quickly, it could be scaled up, not just to your specific area, but scaled up, because we're quite fragmented across the country. And I think I just think it's a good piece of work and worth putting some thought into how it could make a really big impact, and it could make a really big impact. So well done you.
Thanks. I think actually in the Southwest, the inspiration for the project was taken from a study done in the Southwest, where they had a kind of, it wasn't, their study wasn't really to do with COVID, but it was kind of an analysis of oral surgery services. So I'm hoping that we can kind of liaise, now we have Northeast, Southwest, after everything's put together. So
so there's a nice role for you to coordinate it all and implement all your recommendations. That'll keep you busy for the next 5 years.
Yeah.
Thank you very much.
Thanks.
Thank you very much for your questions. I think we need to move on now, and thanks very much for your presentation, Anna, and the questions. And what we're going to do now is I'm actually going to name the places, the awards, in reverse order, and then once we have our third place and second and first places, Nigel is going to say a few words. What I would like to say first of all is thank you to all the judges for both the prizes, and that it was very close with the posters. So please, irrespective of places, you've done great pieces of work. This has been real work. It's been public health in action, and you should all be very proud of yourselves. And to present your presentations or in a group where you don't know everybody, you've all done really well, and I've had a really enjoyable afternoon. But I'm going to have to share my screen now and let you know how, you know, I should have some music going, shouldn't I, for the prizes, but let's make sure I get to the right thing. So we've had all our posters. So here we go. So poster awards. So we have in joint third place, we have Ross and Anna. So congratulations on being third place in the BASCD Borrow Foundation Early Careers Poster Prizes. I will be emailing all of you and requiring your details on how to get your certificates and prize money later on, so I'll be in touch. In second is Myra, so very well done, Myra. And our first place winner, as we can deduce, is Rachel. And just want to congratulate you all. I think one of the things that we particularly liked about Rachel's poster was the story and the way that the story was told. All were really important public health issues, but this had a real cohesion, and the story and how the context setting and the work progressed, and it came across very clearly. So well done to Rachel, but well done to all of our contributors today. And now I'm going to hand over to, let's see, I'm going to need to stop this presentation. And I need to hand over to Nigel, but well done to all of our contributors today. So Nigel, if you'd like to take the floor.
Sorry, thank you, Maria. So I just unmuted myself. I have to stay muted because I really am high risk when it comes to noise and disruption. So but yeah, Maria, thank you very much. First, I should say thank you to BASCD, for inviting me and Margaret, inviting us to participate in this meeting. We support a lot of awards, but very few occasions do we get to be so closely involved in presentations, and it's been really, really nice to have the chance to hear the presentations and the discussion. So thank you for that. I mean, Maria's mentioned that the foundation's purpose, and that's to promote the improvement of oral health primarily in children, and we have a particular focus on prevention. And as Maria alluded to, the foundation's work is growing, and in recent years it's expanded through as the scope of the work that we support has expanded. And we're providing direct support now. Over the 5-year period, we've provided direct support to around 30 countries, and indirectly our resources are now reaching many other countries. For example, through our support of WHO and funding provided to other agencies, organisations working in population oral health, within that expansion, the support provided to dental associations had proved to be particularly important, a particularly important aspect of this expansion. And my colleagues and I are certainly proud to be co-sponsoring with BASCD the Early Careers Poster Award. I hope as we grow, our work grows in population oral health, I hope that there'll be opportunities in the future for us to expand our work with BASCD. And if anyone's got any ideas or proposals, we really would welcome them for, again, population oral health related work or research. It's really interesting. I think COVID-19 has blighted most of our, adversely affected most of us in our work, and it's really interesting to hear about the research carried out around COVID-19 and oral health. And I must thank Myra, Rachel, Ross, and Anna for the excellent presentations. And we really enjoyed those, and the discussion actually was most interesting. Should congratulate Myra, Ross, and Anna for being shortlisted for the award, and of course we'd like to extend our congratulations to Rachel for being selected for the 2001 BASCD Borrow Foundation Early Careers Poster Prize. Thank you very much.
Thank you very much, Nigel. Margaret, would you like to say something? Oh, yeah.
I was muted, sorry. No, it's just been a very enjoyable afternoon. I mean, the 4 presentations were just excellent and so informative, and it's a shame they couldn't all have been first, but they were excellent. So thank you very much for inviting Nigel and I.
And would all our contributors like to just come on screen and just to say hello, goodbye and everything? But I just, you know, it's just such a shame in a way that we aren't all in a room where we could all talk with one another. But I do hope that this has been a good substitute for a poster session in person. I've really enjoyed it. My one frustration is having to do all the tech, which I know Ross knows about me and tech and sort of getting up to speed with it all, but there we are. And yeah, so it's it's been a really good afternoon, and I just can't thank you all enough for presenting, for helping me host, and also with the vote of sort of thanks and congratulations from Nigel, the judges behind the scenes, and all the supporters of BASCD who are BASCD members who are online today. And it just really, I'd like to wish you all the best for the rest of the month and the run up to Christmas. And here's hoping to a COVID-free 2022, or at least the second half of it, and wishing everybody all the best. Thanks ever so much. Would anyone else like to say anything, or
just thank you very much. Thank you for the time. It's been great. Thank you.
Good.
Thank you so much. I'm absolutely delighted, and congratulations to everybody who did such a great job today. It was really wonderful to be here with you all. Thank you.
Okay. Congratulations.
Thanks very much. It was a really great afternoon. Thank you.
Yeah. Ross, would you like to say anything? Are you?
Thank you very much.
Yeah.
Enjoyed myself.
Good. Thank you. Great. Well, thanks everybody. And Alex and Shireen, I think, may have left us. I don't know if Alex is still with us. I know Shireen had to go, but there you are, Alex. Thanks very much for staying. So you can see now what might be next for you in the next few years, coming on board, doing a poster with us maybe. And well done with the essay as well. So just gives me to close the meeting and wish you all the very best, and thanks very much.
Thank you.
Thank you.
Bye.
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 Bye, everyone.
Bye. Thank you.
Bye.